We are here today, as I mentioned, for the Crisis Care Continuum. We are looking at assessing county crisis systems needs, shaping your future. These sessions build upon each other, and so we do encourage people to come back and continue to build on the knowledge that you're gaining from each session. They have a dynamic model, so it goes, the content comes and it builds on itself.
So we are going to get started today. Thank you so much for that great introduction. This is the third section of kind of this four-part series that we have been doing over the last year. It kind of stemmed from the presentations we gave in June at the conference. And so we're just going to jump in and talk through our next part of the series, which is looking at shaping the future. So my name is Joy Brunson Nsibuga, and I am the Vice President of the Southeast for RI International. I oversee North Carolina and Louisiana. I'm actually in North Carolina. I've been with RI for a little over 8 years now, always in programming and implementation of new crisis systems and centers for our organization. I also specialize in substance use services and diversity, equity, and inclusion. And I am a licensed marriage and family therapist and a licensed clinical addiction specialist. And I'm going to just end it right there and send it over to Dr. Chuck.
So I go by Dr. Chuck. My name is Chuck Browning. I'm the Chief Medical Officer at RI International. And I've been working with the company since 2009. I'm also the part-time medical director for Behavioral Health Link, which does crisis and access lines for the state of Georgia, as well as mobile support teams for that. So kind of have a foot in all three lanes of this crisis now works. Really looking forward to talking with everyone.
So just some learning objectives. These are the same objectives that we've had over the course of this series. So I just want to do a quick reminder of why we're here and what we're hoping to gain from this session. So for you guys, you'll be provided with data and real world examples of research and context for the behavioral health crisis response system in the US. You'll be provided with information on the intersection of disparities and inequities in healthcare. You'll be able to learn about the most up-to-date information on innovation and technology in the crisis continuum space. We're going to really focus on that learning objective today. And then you will be able to analyze your own behavioral health crisis response system to determine foundational elements, trends, positives, areas of improvement, and really be able to look at your own response system and be able to determine where you would like to go from here.
This is giant looking golf ball is at Epcot at Disney World. And I love this ride. It's called Spaceship Earth. And for those of you not familiar, inside this ball, you ride like a simulated time machine cart that takes you around throughout the ball up and down. And it simulates a time machine where you kind of experience the evolution of human communication and how it helps create our future. So as you're finishing up on the ride, in the back touch screen of your cart, it starts asking you questions about what you would want for your future. And you put in, you know, whether you're inside or outside person, it asks some different poll questions like what we just did. And you enter this in, and then it plays this cute little video that looks like this, where it cuts out a picture of your face that it took and puts you into a little video that shows you whether or not, you know, you take a trip to Mars or not for your vacation, whether or not you have something that brushes your teeth, those kinds of things. You have a robot that walks your dog or not. And it's a cute thing. But I use that story because it gets you thinking about your future and where you're going to go, what you're going to do. And that's a big theme of what we're talking about today. So I ask you, if you could design the ideal crisis system for your community, and a lot of that's happening across the country right now as we're looking at this, is, you know, what kinds of things would you want it to have? I know for Joy, do you have any thoughts on things that matter to you? If you were going to design an ideal.
Yeah, so the things that matter to me, and we're going to talk a little bit about it, and it's been very important to me over my years at RI, has been ensuring the inclusion of substance use, since that is my specialty, making sure that we have the capabilities to address individuals that we are serving in a harm reduction approach. And then also making sure that we're serving individuals in the community. So that diversity piece, making sure we have access for everyone.
You know, when I think about things, obviously I want it to be a system that's at least equivalent in parity to what we have for medical emergencies in our country, so that you have access for everyone in an emergency need, and that it fits the level of care that you need, whether it's just a phone call and that can take care of what your situation is, whether you need somebody to come to you or whether you need somewhere to go, that those things are in place and that they have, everyone has access to it, no matter whether you're insured or not, or what your race is or your age. And that hey, whether you're rural or urban, that's a topic that we're going to talk about, is, you know, or even frontier. And so we'll get into that subject a little bit. I also think another key part, if you had an ideal system, would be one that's based on standards and evidence. You know, we have so many things in our emergency departments that if you go in with chest pain or having a stroke, there's years and years of data and studies that show what things work and what things don't work, and what to measure, that creates protocols that help guide best case, the best evidence practices related to that. And I'd love our system to have that. For emergency crisis services, for behavioral health things, one of the most important things I'd love to see is a system that embraces people and truly helps them de-escalate their crisis in a culturally competent way, that connects to people in a trauma-informed way, that actually does more to decrease trauma and help support people than to create more trauma, that helps them connect and stay connected with their family and their supports. And also one that helps avoid contact with law enforcement unless it's an issue of imminent safety. So those are some of the things that pop into my mind when I think about it. If I was doing my touch screen for a crisis system, the things I'd love to put in and what I'd like to see on my video.
Yeah, I would absolutely agree with that. What you're describing is something that I would say, if my family's in crisis, I would send them there. So creating these systems where we would be okay with, and even very passionate about sending our family members to the different services that our communities have. So just to do a quick recap on what we're talking about today, we're talking about the Crisis Now model and the 3 core services. So those 3 core services, as Dr. Chuck was saying, think about that parity with the medical system. So if I have chest pains or if I'm in a car accident, I know there's a number to call. I know when I call that number, there are individuals that are going to come to me, and then there's somewhere for me to go, the ED, because I'm having a medical crisis. Jennifer put in the chat about psychiatric boarding, and this system really looks at addressing that. So making sure that when someone is in a behavioral health crisis, whether that is substance use, mental health, and the like, that there's someone to call. There's someone to call. And when you call that number, which will soon be 988, that there is someone on the other end who can address that crisis. There's someone who's competent. And if you need further, then there is a crisis mobile team that will come to you wherever you are. And it's a 2-person team that will come out to you and assess you and figure out how, as Chuck said, to de-escalate that crisis in the community. Just as EMS does. They don't take everyone to the emergency room. Some things they can handle in the community. So really looking at not a transportation service, but being able to provide interventions in the community and to keep people in the community if that's what they need. And then the last piece is the somewhere to go. So if someone needs a place to go, a that there is a crisis receiving center or some type of place other than the ED for individuals to go when they are experiencing a behavioral health crisis that will accept them, that has the space and capacity to accept them and treat them low barrier access and to be able to handle the symptoms and challenges that that individual has, keeping them in their community, treating them there, and then being able to do a warm handoff to community services, their families back to the community. So the Crisis Now model really focuses on these three core services. And we have been talking about these services over the course of the last two sessions, and we'll be continuing that today in how putting all of these three services together really impacts the community and being able to address individuals where they live and being able to ensure that the right level of intervention is available for the person when they're in a behavioral health crisis.
And Joy, these are just the core basics of what Crisis Now recommends. We're gonna, as we talk about shaping the future, we're gonna talk about some bells and whistles and nuances and other things that can layer on to potentially help it even more, as well as practices that you want to consider being done in your community the correct way to get that ideal system in terms of how it operates. So we'll be getting into that.
Yeah, and going back to the rural versus urban versus frontier, this is also those core services that can be kind of moved and shaped to fit whichever type of community that you are in, and being able to be customizable to your area.
And as part of this, we're also talking about each of you shaping your future. So please be interactive with us too, and asking questions and thinking through, just as we've been doing in the homework sessions in our past two, because there's so many different ways that people have ideas and ways of implementing this around the country. It's definitely being moved forward with implementation of 988 going forward, and we're going to be featuring that, but we want to try to cover some different models and how there's some potential differences in the way that you run those as to how that may impact your system. So for those of y'all who aren't familiar with the sequential intercept model, it's from SAMHSA. This is from SAMHSA's Gain Center, and basically the whole concept is it's looking at a model that helps look at how you avoid criminalization of people with serious mental illness. And as you can see, there's different intercepts where people come into contact with law enforcement. And so when you're designing a system for the future in crisis care, which definitely ends up having people oftentimes being arrested for either mental health or substance use concerns, rather than getting into treatment, one of the key things that we've been moving forward as a country is this move to try to help separate out as much as possible law enforcement from coming into contact with folks in crisis out in the community. And so when you look at this, every time 911 gets called, you automatically have a chance that law enforcement is going to be involved in being able to help that. And it's not law enforcement's fault. We created this system where they've become the de facto option to go out and support when someone needs to come to you. So one of the beautiful things about shaping the future is with 988 coming out, it actually gives us a chance, if you have the right setup, that we'll be able to do an intercept zero. So before contact with law enforcement, being able to actually call and potentially be de-escalated with specific support from a 988 perspective that might handle your crisis there for hopefully 80 to 90% of calls. But for those other calls that need somebody to come to them, if the right technology and connections and access of enough teams of mobile support is in a community, then you have an option of people being able to be seen by crisis mobile teams rather than law enforcement. So that now you're reducing only people who are in imminent danger to solve for others that might have law enforcement participate in the call, either primarily or as a backup from a safety perspective to a crisis mobile team. So as we move forward, you really can lean into being able to help law enforcement work on public safety and those types of issues and not having contact if we implement the system correctly.
Absolutely. And one of the other ways, I know we've had conversations with law enforcement, is if they are called out to the scene first, having this system set up also allows them to have resources for them as well, so that they're able to call the mobile crisis team out to support them when it is a behavioral health emergency. So there's also the opportunity for that convergence, and then law enforcement being able to leave the scene, and the mobile response team remain to support the individual. Okay, so we're going to go into some data forecasting and performance as we're looking at the future. So for one of the things that is really important, looking at systems for RI, we really started pulling data from our Phoenix, Arizona programs, and really looking at the impact from there. The interesting thing there is that the continuum is not just RI. It is several other organizations that have come together between the call center, 3 crisis receiving centers, and the mobile teams. It's everyone working together. But by using data, as you can see on the screen, with a county that has about 4 million people, and they're concentrated in certain locations. And so you can see the placement of the crisis receiving centers is in this parallel line and certain distance apart. And it was done that way on purpose, and really looking at how to make the biggest impact, really layering the number of individuals that are in the county over each other, and looking at where individuals live, and then being able to place services so that the population there doesn't have to drive more than 15-20 minutes from anywhere within that county to be able to receive services. And then as you thinking through the facility part, thinking about the mobile response team part, where would they need to be placed in order to be able to have that 1 hour response time to get to someone? So a part of this is not just bringing in services, but strategically looking at populations where individuals are, using GPS location for mobile response teams, so that we know kind of where they are and who's closer to an individual that calls in. It is really about being able to use the tools that we have to be able to ensure that individuals have the shortest amount of distance to be able to receive care, whether that is calling in, someone coming to them, or for them to get to a crisis receiving center.
And Joy, one of the cool things about Arizona that's unique, they don't have all 3 lanes functioning to full fidelity of the crisis now model, which is the basis of SAMHSA's national toolkit on behavioral health crisis. But what they do have is decades long work of a requirement that if you operate a crisis receiving center, that you truly function like an emergency department, and is truly no wrong door. So in this area of population of about 4 million, there are still a lot of law enforcement contact with mental health out in the community. But one thing that does happen is when law enforcement meets with someone, they can encourage them to voluntarily come with them, or even if they're taking someone against their will due to concerns of safety, they are geographically located where there's different centers spread out. And any of these 3 centers run by 3 different companies, it is a requirement when you operate in this area that when law enforcement shows up to drop somebody off, that they're in and out in less than 10 minutes. We average under 5 in our location in Arizona. And therefore, they are moving on to do public safety, and not having board time or what they call wall time in emergency departments, which oftentimes becomes a reason that law enforcement doesn't want to deal with mental health. They don't want to get stuck, and they'll actually maybe sometimes then that'll increase the chances that it's easier to book someone on a nuisance crime and take them into jail, things of that nature. So the way the system's created, it makes it really easy for people to get immediately into access for care if they're with mobile support in that Phoenix area, or with law enforcement. And so some of the numbers and impact that does, Joy, in 2017, they looked at the numbers, and this was again with a 4 million population. In 1 year, having these centers work like this, what kind of impacts did it have? So I think it was Jennifer that asked about psych boarding time. Jennifer, this number is gonna really surprise you. 45 years of ED boarding time in 1 year saved by having access of people being able to go to these crisis receiving centers instead of being in the emergency department. 37 FTE of law enforcement positions, full-time positions that were able to be diverted to use for public safety instead of that. An overall savings to the system of over 250 million, and savings in the hospital ED system, or health savings and hospital savings on cost of 37 million. So you talk about significant impact of numbers. So you've got this business case scenario that makes sense to do it this way, which is why it was developed in the first place. But then on the same end, you're also creating behavioral health specialty care for people when they need it. Whereas a lot of times in different areas of the country, emergency departments are not necessarily equipped to do a lot of support, and it's not necessarily the most trauma reducing situation to go to when you go to a hospital in an emergency room in crisis.
Well, that's not usually why they're there too. They're there for the car accidents and heart attacks and all of those things that they do really well. And so having behavioral health be able to also do what we do well creates that opportunity. So the last statistic that or thought that we like to put in there is considering that all of those numbers, but how that person or those people that were able to be impacted by this data is just priceless. Because they were able to access care at their level and when they needed it, and then were able to be discharged back to a community provider for follow-up care. I'm actually going to stop. There is a great question in the chat, and I'm going to ask Dr. Chuck this question. So I think this will be a great question for you. So Tara says, I'm curious, in the Crisis Now model, are the response people always able to make face-to-face contact with a person, or is there a rate where they travel to them and are unable to find or locate them?
What a great question, Tara. I'm not going to say that never happens, but I know for my company that does mobile support in the state of, in 2/3 of the state of Georgia, once mobile support gets activated, oftentimes the person is either staying on the line with the call line person who activated that, or the mobile support person is then calling them and connecting with them, the staff, as they're on the way to visit them. They do things like a safety assessment about the environment, understanding if there's like dogs in the yard or things like that before they get there. If there's concerns of weapons on site or need for emergency medical care, things like that, those are things that are kind of screened in that process. I don't think it's a high number that happens, but I'm sure it happens at times. And in which case then they have to, usually a lot of times that would end up occurring more from someone where maybe it was a parent or family member calling for someone, and that person knew that somebody was on their way and tried to, kind of get out of the scene so they wouldn't have to interact with that team possibly. But it still doesn't happen very often. So, I mean, I'm sure even with ambulance services and paramedics that happens at times, that they go out to a location knowing that they're supposed to pick up a call and something's happened. But it's not a common thing that we run into.
Okay, so looking towards the future and looking towards what's coming, again, looking at that data. So just from a data perspective and thinking about the calls. So this is the call center section of this. Are you snacking?
It's a piece of gum. My throat's really dry and I'm trying to give it some moisture.
I was like, come on. Okay, sorry. So, and just so everyone knows, Chuck and I have worked together for over 8 years. Almost 9 years now, I think. So, we kid each other all the time, all the time. So just thinking about that call center piece, and with 988 coming and all of the changes, we are looking at the data and the impact that this may have. So we estimate that there's about 13 to 15 million calls to local, county, and state crisis lines currently. We estimate that there's about 2.5 to 3 million calls to the suicide prevention lifeline currently. And then we conservatively estimate that there is about 24 plus million calls to 911 currently. So that's where people call when they're in a behavioral health crisis, they call 911. So we're thinking that there could be potentially about 40 million plus annual calls to 988 upcoming. And thinking about for a local, county, state crisis line going from 13 to 15 million to 40 million, thinking about the impact of calls coming into 911, how do those get transferred over to 988? How are states and counties going to work that? So we're really looking at how all of this is going to impact at the local level, the county level, and the state level. And just by pure size, number of calls, and all of that. Because the most important thing for 988 is that it's effective, it works. There's someone to answer, there's someone to take the time and really assess what's going on. And so the concerns right now are around how the implementation is going to happen. How do we make sure we have the workforce there and train to support the calls that are coming in? And then how do we have the services underneath that support these calls as well? And in the 3 lanes of the crisis now model, for the calls, you have to have mobile response, and then of course somewhere to go. Chuck, what would you add?
Well, I just think, again, we're talking about shaping your future in your community. So one of the tensions I see nationally about implementation of 988 is, as you can see, there's a lot of different smaller local, county, and state crisis lines. To truly run in the eventual goal, a line that not just that does suicide prevention, but can access and answer all behavioral health crisis calls when you look at this volume, and have the staffing to be able to do that, as well as have the technology to be able to help support, like 911 does, connections to mobile support teams, to paramedics and EMS, coordination with 911 law enforcement when there is imminent danger. All of the intricacies that are going to need to be in place. It may be tough for some of the smaller services to be able to manage that. And so as it's being developed in communities, one of the things that we see in tension is, how does that happen? How are people going to adopt best practices? And this tension a little bit between whether or not it's going to be just a suicide prevention line or really truly function like the 911 of all behavioral health calls. Because if you just have suicide prevention, there's going to be a large percentage of people that don't get the benefit of having that support system.
The future, so let's look at technology, because that's going to be the biggest part, or one of the biggest pieces going forward, of how this is all going to work together. Being able to take advantage of technology and the tools that are out there to help us do the work that we're going to need to do. And a part of supporting our workforce as well is going to be updated technology. So Chuck, you want to go into the next section?
Sure, Joy. That's such a good point. So I actually kind of led into this when I was talking about 988 and some of the technology requirements it's going to need. Mobile support teams are going to need GPS location type services like Uber has, and DoorDash. I mean, you're going to have systems that help know how to do that. And they're out there, but they just need to be tailored and fit to that. And then, we need to have better evidence-based practices and coordination and technology in the flow of our operations and crisis receiving centers. And oftentimes across the country, some of our crisis centers don't have that level of efficiency or that type of infrastructure to do that. So if you look, the next slide, please. To do this, we don't have to be a Star Trek deck or out of Star Wars or something like that. And next slide, you don't have to be quite like NASA, but there are some really cool innovations going on around the world related to behavioral health data and crisis care. So this is the next picture actually really does look like these, and it's something that's really happening. So in Gold Coast, Australia, where we've done consulting, this is their hive that they use for coordination of all data operations, efficiencies and flow and valve flow management and things like that. Key performance indicators are being managed by people who just are working on analyzing the data through technology. This is for their medical system. They are currently developing the same types of tools and infrastructure for their behavioral health and crisis system. So there is, again, a movement forward to being able to get more sophisticated in the ways that we measure what we do and look at what's working and what's not working. I'll tell you another really cool thing that's going on as an innovation is taking expertise on systems outside of behavioral health experts and just using systems engineers to help look at our systems that we're developing. So there's a really cool article that's coming out that just came out this week on Crisis Talk, which is the Crisis Now website, about that being done in LA and their use of a purely systems engineer who's not necessarily a behavioral health expert on just how pieces fit together and how to design your system to do what you want it to do. So important thoughts as you're shaping your future.
So let's start thinking about the future of your behavioral health system. What aspects of the crisis system can be improved from a systems perspective? How are those pieces working together? In the example with Arizona, it wasn't just one provider working together, it was the whole system working together to be able to provide those results. It wasn't just one. So what are the aspects of the crisis system and what can be improved from that perspective? What are the current operational thoughts about a call center in your area? Mobile transport, crisis receiving centers. What are the current operational thoughts? Because there are some differences depending on if you are in an urban or rural or frontier area, or different kind of makeups of teams and different types of receiving centers, different levels of call centers. And then based on these choices, what are the potential impacts to your community? So some essential care practices, and thinking about trauma-informed SAMHSA toolkit type principles. If we could keep going so we can get some of the, there we go. Addressing the recovery needs using peers, individuals that have lived experience into your services across all lines of your crisis continuum, and being able to make sure that we're utilizing trauma-informed care, or I've heard recently, trauma responsive care. So even putting it into practice, not just being informed, but then taking the next step and putting it into practice. Using services that really have an emphasis on suicide safer care, or being able to ask those questions, not shying away from those questions, and being able to, sit with individuals when they're experiencing suicidal ideations, and really being able to address their concerns in that way. And ensuring that there's safety and security for all staff. So Tara, that goes directly into what you're talking about, a one person versus a two person team. I think my heart would probably drop if the GPS signal just all of a sudden just disappeared, like the car just disappeared. But really looking at how to make sure we have safety and security for all staff. Coordinating with law enforcement and emergency services. There is going to be a time where the systems that we have currently in place are still going to be the first line of defense in your county. So being able to coordinate with law enforcement until that transition in your county happens to where your behavioral health system is being responsive to the needs of the individuals, and individuals are calling that behavioral health crisis line, calling for mobile crisis, and then emergency services. We've had situations where individuals will walk straight past the crisis receiving center and go to the emergency department because that's what we know to do. So until all of that education comes into place, and the services are there to support all individuals, we need to make sure there is coordination. So wherever someone kind of enters the system, they're able to then get transitioned to the right level of service within the behavioral health crisis continuum. And then this one is one that is really important for me, and it's about not creating a kind of niche boutique type services that individuals do not have access to. If we're creating services that only support a part of the population, then we're not doing our due diligence with serving our entire community. And that includes if we're not being able to serve individuals that have substance use challenges, then or have substances on board, then we've just separated out a section of our community. If we're not able to figure out ways to address kind of those chronic illnesses that individuals have within our behavioral health services, and being able to coordinate with that, then we've separated out a section of our community. And for example, we all know that individuals of color have health disparities and higher prevalences of health issues. And so if we're not working to accommodate those chronic health conditions within our behavioral health crisis receiving facilities or services like that, then we're separating those individuals out. So just looking at how we have come to have exclusionary criteria or steps or barriers to entering services. And so if we are putting things into place, making sure that they are not meant to exclude certain populations. And so making sure that the crisis continuum that is being developed is really meant for everyone.
When we screen out in any of those layers of care, we're entering the chance that we're more likely, because the typical screen outs are this person's too intoxicated, they're too dangerous, they have too much risk because of this or that. We end up, I feel we know that we end up increasing chances for more implicit bias and continued demarginalization of populations. And so one of the things that's beautiful about creating access for everyone is it does increase your chances to have what we talked about in that ideal crisis system, a system that's equal access for all. And so that's an important piece of this, but it's not easy. So we talk about, like in our crisis receiving centers, how hard it is to be no wrong door. You have and be safe. And so I'll give you in a situation in our center in Peoria, in Phoenix, Arizona area, 82% of folks come in the back of a police car, either voluntarily or involuntarily. And there's a lot of methamphetamine use and intoxication in that area. And so a lot of the folks that show up at our door are challenged with intoxication of methamphetamine. They may have a significant history of violence. And so there may be a 250-pound guy that 4 police officers bring in and leave with you. And again, you have to manage this safely. And so how people do that to work on being safe can be done in different ways. Some people use it by keeping folks in chairs with big bouncer type folks and security officers and glass plexiglass windows to keep staff separate from the folks that they're serving. They still say no wrong door, but is that really a place you would want your loved one to be, or that you would want to be if you were in crisis? So we talk about this at RI, this thing called the fusion model. And it's how can you keep staff safe, but also be an environment where you want your loved one or a family member to be cared for. So if you could hit these slides real quick, and so we call it like, how can you do no wrong door and say yes and create access to everyone, and at the same time have a recovery of care. And we call this the fusion model. And that's the way that we work on pulling these things together. And it's very challenging and hard. So one of the things that we do is we focus on peer-powered practices. And so for peer power, for us, the definition is not just the use of peers, it's that the peers are one tool to help super support the development of our peer power practices in terms of voice and leadership and being part of the team, both in the leadership of our company, but also on the floor, working with guests, but also that all of our staff, whether you're a nurse or a provider or a clinician, as well as peers, are using what we call peer-powered practices. And if you can just click through on the slide, we categorize ours into kind of 5 big ones. So working with people, not doing things to them, which is so easy to do in a crisis situation. Being strengths focused, focusing on people's whole personal wellness, which a little bit Tara was talking about that a little bit when we were talking about ways to approach people. And then using trauma-informed care principles, and then having a no force first policy, meaning that we really, every time we have a seclusion and restraint event, it's considered a failure of treatment. So those are our 5 main peer power practices we use at RI. But I encourage, and if you think about SAMHSA's National Toolkit, it includes these concepts built into their essential care practices. So when you think about a recovery focus, so many times when people go to an emergency department or are having challenges with a crisis, focus is on the symptoms, the illness, and what's wrong. And we like to really work on our staff thinking about how to engage and connect with people, and looking at every crisis situation that happens as an actual opportunity to connect with that person, and helping that person see it that way, so that they're focusing on their strengths, how they've been resilient, the courage that they took maybe to seek out to get help. And this is true for all lines of care, whether you're in the call line service, mobile support, or working with somebody on more of a crisis receiving center type situation. So that's, again, strengths-based is one of our peer power practices. And it's just, it's not easy to get your staff to do that, but it's a philosophy that we think makes a big difference on helping de-escalate and helping people get out of crisis sooner when they're treated that way and are empowered to think about their situation in that way. So when you think about trauma-informed care, there's so many different elements to that, but it truly, having it not just being in training that you have, but that you actually bridge that gap between knowing what trauma-informed care is and actually doing it on a daily basis. And that means your staff, which this is tough work in crisis. So your staff has to be able to feel safe, and they have to feel equipped and trained and supported with different leadership structure that you have, ability of tools and resources they have, so that they can be centered and be in character for the role that they're going to give of creating this trauma-informed care experience with the people that they're interacting with. Peers can be unbelievable at helping make that happen, as well as influencing empathy and an awareness of that when you're working with people. And so this is a really tough one to get done right. But when you do it right, and it's collaborative with being inclusive for all and being considerate about what is engaging and not engaging for different groups and different cultures, it makes a big difference in your ability to create an experience like that for everyone. And so one of the things that we do to help with engagement, and it also makes a big difference in some of our other peer power practices like collaboration, is we focus on our language at RI. So we actually you've probably heard us say guest. We don't say patient, we use the word guest. We have certain ideas and guidelines that we do in our training when you're hired and when you're doing your onboarding about the ways that we reference certain things and avoid certain typical hospital or behavioral health lingo. Some cool things that we did were innovations just to throw out there and think about doing in your community is one of the things that can be really frustrating for people in crisis is having to repeat certain parts of their history over and over again. It can be traumatic, it can be frustrating. And so we talk about collaborative and concurrent documentation so that a person set it up so that if you have like one person doing a piece of the interview, that you make the next staff member who's going to be working with that guest or that person be able to read what that's done so they don't have to repeat it and rehash it all over again, as well as doing it with the person so that they are seeing what you're putting in their chart and agreeing to it and understanding it and using their own words as much as you can in your documentation. We actually did specific do with clinical guides. So for a nurse doing med passes in the center, what are ways you can be more collaborative and work partner with people rather than just being bossy and saying, hey, it's med pass time, come take your medicine. We found that one of the things that from a language perspective that was tough on some of our guests, going back to a trauma-informed perspective, was that they didn't have expectations of what was going to happen. And so there's a classic like top 5 to 10 questions that get asked, and different staff members, if they didn't have the right answer and kind of gave inconsistent answers. So typical questions: why can't I smoke? When do I get to get out of here? When can I see the doctor? Those kinds of things. If you don't have a set of systemic questions to be able to make that work, it can create frustration and sometimes cause escalation of behaviors. So working on that and then giving our staff tools about how to be sincere and genuine in the way that they consistently answer some of those questions was a really helpful thing. Joy, you'll talk about the environment and the importance of that. And I think we're down to less than 10 minutes. So we may actually finish some of the recovery and practice, and then we may have to, in our 4th section, cover substance use and suicide, safer care.
Yeah, I think so as well, so that we don't kind of rush through those sections. Those are really important. So a part of this is also the environment for behavioral health systems kind of across the board, making sure that we have environments that are comfortable, that are warm, that are welcoming, that really have an impact on someone's well-being. We look at it as this is the opportunity for someone to think about what they would like to do going forward. Think about how they want to enter into recovery or address the challenges that they are experiencing. So having warm, comfortable environments, having spaces that are wide open so that there's observation, but it doesn't feel, that there's like this fishbowl effect. There are peer staff who are able to go out and sit on the couch next to you and talk to you about those concerns. Doesn't feel hospital-like. Have warm colors, artwork. All of those things really have an impact on someone coming to a behavioral health center or being willing to be supported in a facility. So thinking about, there's lots of stigmas out there. There's lots of statements that have been made, but really when you look at the type of facility and having those doors open and welcoming everyone in, that really starts with the environment and ensuring that the environment is set up for the services that you would like. And that includes, we were talking about call centers, that documentation, those questions, all of those things. When you go out into the community, again, you are bringing that environment with you. What types of engagements do you want to have with the people that you're serving? So it's an extension, right? And then putting that over into the facility as well. So we've seen that there's been a positive impact when we pay really close attention to the environments that we have and in ensuring that those environments are set up for recovery.
And this environment is so important, Joy, when you think about things like mobile support teams coming out in an unmarked car that doesn't look like a police law enforcement car, and the changes that can make in trauma experience, what gets triggered, those kinds of things. So it's applicable along all lanes. We actually created tools to measure the way we engage with people, and tools that have questions about how they feel subjectively in their recovery environment. And so thinking about in your system that just like we measure fever, temperature, blood pressure, we have scales for anxiety and depression. Are you measuring, satisfaction in the moment of how well you're engaging with people? And the next slide is some certain questions that we use to look at scores of subjective self feelings of different types of recovery oriented things. And how does that change in terms of escalating or de-escalating during a crisis situation?
Thank you for your attendance and for your participation. Please share the information with other folks